Okay. Well, thank you everyone for coming to the grand round today. You know me and Paola, I'm PGY4. The first of us, the first victim, giving the grand rounds. So yeah, I wanted to touch on a topic that I myself, being trained at a VA, feel like I'm really deficient in, even in internal medicine. And I've tried to do my best whenever I have rotations outside of the VA to try to compensate with women, especially during pregnancy. And now that I'm in a nephrology fellowship, I think it's going to be really important for me to double down on that and try to continue to look into that to grow and recognize my deficiencies and kind of like work through that. And so I thought this was like a good place to start. I've had like 1 or 2 dialysis patients who are pregnant. And I've always wondered, right, I've had some explanation on why we do like intensive dialysis and the modalities and everything that goes to it, but I wanted to like do a deep dive to kind of like understand it better myself. So this is a review kind of that I did to kind of like understand where everything was coming from and make good decisions based on that. Okay. So starting with some objectives, after this presentation, I wanted to be able to present the outcomes of pregnancy to patients who are pregnant on dialysis, instruct a bit on how to approach the dialysis patient who wants to become pregnant, and talk a bit about the changes to be considered during pregnancy for successful outcomes. So let's start with a bit of history. There we go. Okay. So in 1971, the first case of a successful pregnancy while on dialysis was reported. And then it wasn't until like later during the 1970s that more cases began to be reported of patients on both PD and hemodialysis that were becoming pregnant and were having the babies. However, both the maternal and the fetal outcomes weren't great at this time. Later on in the 1980s and in the 90s, studies began to show that an intensified dialysis regimen as like parallel to improvements in dialysis in the general population, it was started to note that improved patient outcomes. And it was the first study was published that showed that an increased intensified dialysis of around 20 hours per week showed improved pregnancy outcomes. And you can see the difference from one that was done in the 1980s that showed around 37% successful pregnancy, on another one that was done a bit further, close to 20 years later, that showed 50% successful pregnancies of patients on dialysis. Now, in the modern era, so this is in like the last 15 to 20 years, more registries and more studies have come up that have showed that more patients are able to have successful pregnancies on dialysis with improved data, improved prenatal care, and improved dialysis overall. So now the birth rates are a bit more comparable to what it is on the general population, around 70 to 80% in some series. So diving a bit more into what the modern era is bringing. So the pregnancy rates of patients on dialysis, even though the success rate of the pregnancies are higher, the actual pregnancy rates are still low. And we're going to talk a bit more about that. So a study based on the USRDS, the United States Renal Data System, from data from the 2005 to 2013, showed that pregnancy rates on patients on hemodialysis was around 19.3 pregnancies per 1,000 patient years. That compared to the PD patients who had lower pregnancy rates, and this is pretty consistent across the board on the different studies that I read, that they have even lower rates of pregnancy. So this study reported 9.3 per 1,000 patient years. And that compared to the general population, which is 85 per 1,000 patient years. So you can see how big of a difference is. I included another study at the bottom that also reported like an overall, that patients on chronic dialysis, the rate of pregnancy is around like 11.1 per 1,000 patient years, but this is more dependent on the patient, the actual patient, their comorbidities, and the type of dialysis that they're on.
Can I ask you a question? You can go first.
No, you go ahead.
Is this pregnancy at the time of dialysis when you're saying PD or HD?
Yes.
Because
Wow.
a PD patient wouldn't be on PD and they're trying to be pregnant, right? They're switched to HD possibly.
A lot of them do,
Right, so
yeah.
it should
But
be
this is-
historical lead comparison, the historical HT rather than the time of pregnancy.
So I would need to clear that, actually, I'm
You
not
understand
sure
what I'm
that
saying
this
though,
is,
right?
I understand what you're
Because
saying, because I
you're
know
not
that
gonna
a
be
lot of them are
confused
sometimes like.
when you're elected with becoming pregnant, so then finding people who are on pretty by incident.
Mhm,
then
it is, yeah,
dying, right? So that's gonna be significantly low compared to HT.
yeah.
So Paola, my question is, how do they define general population? And so what are they comparing to?
So. For the general population, I tried to look up in general, like the patients of the same age. That are being considered. And like the ones that are on dialysis, so around like
Ages,
15 to 44,
ages 15 to 44? Okay.
yeah. So what are the pregnancy outcomes? So, live birth rates on patients on dialysis, is obviously important, not only how many patients become pregnant. And overall, over time, the rates have improved. They're generally reported now at around 50 to 87%, which is much better than what we were seeing in the 1980s and 1990s that I mentioned before. But this is very dependent on the dialysis intensity and again, the patient characteristics. So why does this happen? So as Dr. Shah brought up, right, fertility is an issue, especially for patients on PD, and we're going to talk a bit more about it. But overall, patients who have history of CKD have are known to be less fertile, right? So fertility decreases as the GFR declines, and when patients have a GFR less than 15, practically everyone has menstrual cycle irregularities. And they even become anovulatory, even though they may see like regular bleeds. And all of the, they also may have early onset of menopause at around 4 years before the general population as well. So all of this is thought to happen because of a dysregulation in the hypothalamic pituitary axis. And so I found this picture from a Nature article that I really like, and it kind of compares the normal ovulation and menstrual cycle in non-CKD patients versus CKD and to an extent dialysis patients. So you can see on the first one, so it's a review of physiology, a tiny bit, right? How you have the pulsatile GnRH release, and that stimulates LH, and then that is what stimulates the ovarage to release the ova, and then eventually become pregnant, right? And you can see that all happens with that LH surge that we see over in the dotted orange line on the left side. And when we come onto the side of the CKD, you can see how that doesn't happen. And why does that happen? Why doesn't it happen? Prolactin is a big issue in these patients, right? So prolactin isn't eliminated in the CKD patients, and they tend to have higher rates. And so prolactin ends up inhibiting the pulsatile release of the GnRH. And if we don't have that pulsatile release, we don't have that LH surge, and we don't have the release of the ovum. And that's where the anovulatory periods come in. So fertility and PD. So when we look at the data overall, as I was mentioning, across the board, most of the patients who are on PD have even lower rates of pregnancy. And why is that? So I found this very interesting, right? You're instilling hypertonic solution, and you're also just like putting fluid out there. And when you think about the anatomy, the ovum has to travel some ways, right, to get into the uterus, and just having extra fluid hanging around in there and causing inflammation may cause difficulties, a process that is already going to be difficult for these patients to be even more difficult. Also, if they've been on PD for a while, the inflammation, and they've had peritonitis, all of that can cause some structural changes in the anatomy, and that can cause it to be even harder to. Are you gonna ask something?
Same argument again.
Like, is this based on somebody's opinion or there is data?
Send you the paper where I read it from.
Like a review article?
I don't remember
People
what
become
was your-
imaginative. It's
They're looking at the retrospective data and trying to make the hypothesis.
These are
It's what it looks
hypotheses.
like.
Yeah.
Based
these are
on the
hypotheses.
retrospective data, which are erroneous anyways, right? That's what
It's
I'm
all
saying.
retrospective.
Yeah, so
From-
I think I think Dr. Shah was making that point, and I won't use the word fertility there. I would use pregnancy in PED, and I think that's a reasonable statement. Dr.
Okay.
Shah probably was making a point there that considering how we have practiced medicine
Mhm,
over the last 30 years, nephrology,
mhm,
that we tend to think that PD is a suboptimal therapy, and hence either patients on PD are swiftly shifted to hemo if they do become pregnant,
mhm.
or the other way around, that patients who are planning to become pregnant may not be advised PD. So what I'm trying to say is that it's quite possible that pregnancy rates in PD are influenced by these. I mean, I love the hypothesis, but there is. Okay.
Okay. So why is this important? According to the United States Renal Data System, the USRDS that I referred to earlier, they do an annual report, and on the one from 2023, they reported that around 15 to 20% of female patients are on dialysis are childbearing age. So that is a pretty large percentage, right? And this comes up to 38 to 50,000 patients in the United States that are of childbearing age, and that we should be talking to them about this. And so this is a conversation that should be held with anyone from this age. Doesn't matter if they want to or they don't want to, or they're thinking of pregnancy. And obviously OB-GYN, whenever they go to see them, that's one of the first things that they ask. But a survey that was done showed that only 46% of nephrologists or office staff consult these women on any type of like pregnancy issues associated to that. So to help us out, and to understand, give an example of how we should go about this, I brought my friend. Her name is Maria del Mar Rodriguez Pacheco, but you can call her Mary. And she is a 30-year-old female who is currently on PD. She is ESRD secondary to GN post-infectious. And she has history of hypertension and hypothyroidism. She has been on dialysis for the past 2 years, mostly on PD, all the time on PD, not mostly. She's very compliant with the treatment. She doesn't have any history of PD complications, catheter or otherwise. And she can still make around 500 to 1,000 milliliters of urine. Her medications include losartan 100 milligrams, calcitriol 0.25 micrograms per day, Sabelamir 100 TID, and levothyroxine 75 micrograms. And she is sexually active with her husband. And so she asks us, she comes to our appointment, in our clinic, and she says, I want to become pregnant. What should I do? So that's what I'm going to attempt to answer. So the way that I wanted to go about this is approaching it in like a stepwise process, right? So there's 3 important topics and like 3 important phases during this that we should discuss with our patients. So the first one would be preconception counseling. If they are interested in becoming pregnant, then we would go on to the dialysis and the maintenance during the part of the pregnancy, and then delivery. So now we're going to start with the preconception counseling. So the first thing that we need to talk about to a patient who is of childbearing age, who is on dialysis, is the risk versus the benefits. They need to know about this, whether they want a baby, they don't, this has to be mentioned at any point. So if they become pregnant, the pregnancy is going to be high risk. And they will need to follow up with a multidisciplinary high-risk team, right? An OB-GYN and a nephrologist. And I'm going to have to be monitored pretty closely during this time. There are many common complications from this, including preeclampsia, around 28%, C-section is needed in around 58% of the patients, and a lot of preterm birth are also from patients on dialysis. And that they will need intensification of dialysis. It's something very important that if I were someone who was on dialysis and they told me about the intensification of dialysis that I had to go through, this is something that would make me think twice about if this is something that I want to go through. If the patient does not desire pregnancy, what can we do? So we need to advise them on contraception because family planning may be unreliable. Remember, they have these ovulatory periods, so you never know when an ovum is going to be released, and it may be super risky for them to just do that. So I found this image on kidney medicine that I thought was very good, and it kind of like illustrates all of the different contraception options with the risk specifically for patients in kidney failure, which I thought was very interesting. I'm not going to go a bit into it because, as you may know, our friend is going to present a bit of medications and all of that, but I just wanted to place this here because I think there's something that I'm going to keep in my back pocket. So when I have these conversations. If the patient desires pregnancy, then what do we do now? So first of all, kidney transplants should be encouraged. It is associated with less maternal and fetal complications. And sometimes the pregnancy can even be delayed until they are able to get this transplant. And we need to counsel on medication adjustment and needs for close following that we mentioned before. And in some cases, we may even need a fertility specialist. So let's start with medication management. In every patient, as we did with pregnancy patients, we need to eliminate the teratogenic medication. So that includes any RAS blockade medications that they may have, statins, etc. We're also going to have to convert to pregnancy safe antihypertensive medications. That includes mesodopa, labetalol, or long-acting nifedipine. And the blood pressure goal is going to be less than 140/90. Vitamins. So they should continue to take any prescribed renal multivitamin that they are on, and we should obviously start them on folic acid. And that other that I included because you may need to hold calcitriol, right? These patients may become hypercalcemic from the large amount of bone turnover from all the hormones that are going around their body. So this is something that we're going to have to monitor as well. And stop phosphate binders, not because they have anything teratogenic or anything, but because the optimization of the dialysis is going to probably make that phosphate be lower. So we can do this preemptively. So remembering our Mary's medication list, she was on losartan 100 milligrams per day, calcitriol 0.25, sevelamer 800, and levothyroxine 75. So we're going to stop the losartan, hold the calcitriol, and monitor to see if she's going to need it. The sevelamer, that's the one that I put the asterisk because I already mentioned what I was going to say here about monitoring the phosphate for them. And we're going to start nifedipine to control that blood pressure to that goal of less than 140/90, and folic acid as well. So moving on now to the dialysis during pregnancy and the maintenance. So during pregnancy, we're gonna need to follow these patients pretty closely, right? We're gonna need to follow them as a high-risk pregnancy. So that means more appointments with the OB-GYN, more follow-ups where they're on dialysis by us. And we need to do labs pretty closely as well. We also need to counsel them on the nutrition. These patients are gonna need a higher protein intake. Dialysis removes some of that protein. They need a lot of building blocks for that baby that they're building up in their belly. So I found that some studies recommend around 1.5 to 1.8 or even higher grams of protein per kilogram per day. And we're going to liberalize the phosphate in the diet for the reasons I already mentioned. Infections is also another really important topic with these patients. They're already high risk. We don't need more situations happening while they're pregnant. So we want to be really attentive to those axes to make sure that we catch any early signs of infection and treat them appropriately. And even though they're on dialysis, we can't forget that they may still be making urine and may still suffer UTIs, and we should screen them as such. Okay. Anemia is another important topic. So these patients are going to be in a relative EPO deficiency because of the high demand of RBCs from the placenta building and the baby. They also may have loss of iron and RBCs while on dialysis, and they may also have EPO resistance from the inflammatory cytokines that they already have as dialysis patients. So EPO is something that we should keep as well in the back of our minds to increase, adjust, or start for patients who are pregnant. Preeclampsia and hypertension, we should follow really closely as well. We should screen for preeclampsia in this patients as we would in the other patients by monitoring their blood pressure and also during dialysis. And we can perform laboratory chemistries by performing CBCs and liver function panels at least twice per month. And again, because it is a high-risk pregnancy, they need to get the test for fetal unrest. Make sure that we catch those early on. So for dialysis management, prescription. So this is the part that I also wanted to kind of like dive a bit more into, because I wanted to understand where all of this intensification came from. And so I found that there was a study in 1994 that's called The Frequency and Outcome of Pregnancy in Women on Dialysis. And this study was a survey that was sent to different dialysis units. And they found, and they suggest, and they don't write this explicitly, that their dialysis intensification isn't written in any part of this paper. But from people in the future reading back on it, it seems like they would suggest from the data that they presented that the success rates of patients on dialysis were better on patients who were noted to have like higher dialysis rates. You see that? Yeah. So, and during that time, we saw that also some changes that included like more frequent dialysis and better uremia control and improved obstetrical care were all improving the patient outcomes, the pregnancy patient outcomes for them. Another study in 2008 that was by Bura et al. That was called Successful Pregnancy on Nocturnal Home Hemodialysis, was the first one that reported the difference in between like the two, like the actual intensification of dialysis. So they had women who were previously on regular dialysis, and then they were transitioned to home hemodialysis, and that was intensified to a 48 hour per week of dialysis. And so they also showed improved outcomes on those specific patients who had intensification of the dialysis to that extent. In the third study, in 2014, from the Canadian and versus American registry, showed that live birth rates of around 86.4% in women who are dialyzed 36 hours per week, versus around 61% in women who are dialyzed in conventional cohorts, like on the regular dialysis rates. And they found a dose response relationship in them. So less than 20 hours per week was related with around 48% of live births. 21 to 36 hours per week was related to 75% of live births, and over 37 hours per week were related with 85% of live births. So this, if I see this, right, I obviously want to have my patient as well controlled as possible and give them as much dialysis as possible to help them have a live birth within everything that's going on for them. So what are we going to do with the prescription? So increase the dialysis, right? We want that live birth rate as high as possible, and we're going to try to imitate that. So we can do 36 hours per week. Usually it's done divided by 6 hours, 6 times per week. We're also going to aim for a higher potassium goal. We're going to try to keep that potassium higher at around like 3 to 4 by using a 3 to 4 bath to reduce the risk of hyperkalemia. Since they're getting all of these like recurrent dialysis sessions, it's more likely to go down. The bicarbonate, these patients are already hyperventilating, right? So we don't want to make them more alkalotic and cause hypoxia to the baby. So we can have a lower goal of the bicarbonate and just dialyze them on a lower bicarbonate like we usually adjust it, but just for this lower goal. Calcium bath. So I already mentioned that the calcium is going to be higher because of the higher bone turnover and the setting of all the hormones that are happening in their body. And we can dialyze them, we can help them by dialyzing with a lower calcium bath of around 1.5 millimoles per liter. And the phosphate, right? So we know that this happens when we dialyze a lot of patient. Their phosphate is going to be on the lower side. So we want to try to keep them on the higher side by increasing it, stopping the binders, increasing the phosphate in their diet. And if needed, we can even start a phosphate supplement. Or we can add phosphate to that, which I found interesting as well. So what are our targets? So you can imagine if uremia is toxic to the general population, what can it do to a baby? So no live births were reported or documented at least, in patients who had a BUN higher than 60 milligrams per deciliter. Some studies report a goal of less than 50 for patients who are on dialysis, but others even go as far to recommend 30 BUN as the goal. Dry weight. So you can imagine it can be hard to kind of like adjust this dry weight on patients who have a baby growing up inside of them. So what some patients have tried to do, like some studies tried to do, was just increase it by 1 or 2 kilograms in the beginning, just to kind of like compensate. And then during the second and third trimester, increase it like 0.5 kilograms per week during the third and during the second and third. But other studies went even higher, like 2 to 3 kilograms per week. And these increases in dry weight obviously need to be done based on your clinical judgment. And if they need more ultrafiltration or if you see them overloaded, you have to adjust it to the strict rule. That's what I just mentioned.
No, Paul, this seems to be pretty modest weight increase goal. Because I think average pregnancy, what they recommend is 25-30 pound weight gain. Placenta, amniotic fluid, and chronic fetus all take some weight, as well as enlarged uterus. So I think one of the trickiest things for pregnant patients is to manage volume, right? Leg swelling is expected by the normal healthy pregnancy. Right, that's not something we can necessarily point it to pregnant dialysis patients and say, this is abnormal, we're gonna get it to the dry weight. Right.
Yeah, but this is about a pound per week.
Right.
Yeah. About per week from the second to the third trimester.
So that's barely, I think it's barely scratching it. So
I saw like a wide range. I saw the 0.5, I saw 1, I saw 2 to 3. So
yeah, like how do we don't get polyhydramnios, but we don't get oligohydramnios. But thank you. Yes, I mean, I'm so glad you're bringing this up.
So, management while on PD. So, patients who are on PD, this is mostly incidental, right? So, this isn't usually planned out, but if they end up being on dialysis, on peritoneal dialysis, while they're on PD, then it can be beneficial. Why? Usually these patients already are producing some level of urine, and that already gives them a better outcome. But because we're doing continuous gentle UF, it could be better, and we also avoid anticoagulation. You also see less overall instances of anemia, and we have a bit of better metabolic balance and blood pressure balance without all the fluctuations. However, complications. So a lot of abdominal discomfort, right? By having a baby growing in there and putting extra fluid, this is already uncomfortable for the female. So this can be just like the discomfort, it might be enough to get them off the PD. And having the catheter in there can also cause some bloody dialysate and some obstructive complications. So if you see bloody dialysate on a patient who is pregnant and is doing peritoneal dialysis, you need to think about placental abruption, trauma from the expanding uterus, from the PD catheter impinging on it, and be very aware and bring it to the hospital as soon as possible. And then a lot of patients are also associated with like having to do like preterm delivery and premature rupture of membranes. So all of these complications, obviously, even though there are some benefits to it, mostly lead us to put patients on hemodialysis over PD.
I don't think there is any recommendation on that. And first and foremost, going back to your patient, for example, who comes for desire of having the pregnancy, you don't know whether she's ever going to get pregnant.
Right.
So every person that talks about pregnancy, are you going to switch them to hemo? So what I'm trying to say is that there is a little bit, so I think the way you want to visualize this is, you want to visualize pregnancy as a continuously changing process.
Okay.
And so there is going to be a position that you will take at the beginning. So if we are going by anecdotes, right? Like this is the reason why your fertility rate, quote unquote, were low on PD. But if you're going to go by anecdotes, let's say, I can tell you, I have had one patient who became 4 times pregnant on PD. And I'm not kidding you. It's just like, I don't know how good her fertility was. She would deliver, we would switch her back on PED, she would be there for a year or so, and then again become pregnant. And we had 4 successful PED and pregnancy, and then somewhere in the middle we switch. So as your baby grows, there are these constantly, so you have to constantly monitor it.
Right.
And at some point, there may be a reasonable level of discomfort and other concerns that you may want to sort of say, is this the time for us to switch? But then also there are other things that we overplay, right? So for example, we have said that preterm delivery and PRM are complications of peritonitis. Well, imagine how is this patient going to shift to hemo? You're going to have a catheter. The complications are largely related to, they're not mechanical complications, they are related to the sepsis part.
Right.
And so that also predisposes. So I think sometimes we overgeneralize these problems, but I think, so there is a position to be taken when planning pregnancy, there is a position to be taken in the early pregnancy, and then there is a position to be taken somewhere around 15 to 20 weeks, where the rest of these, because I think all the concerns that you mentioned are largely a
Towards the end.
15 to 20 week onward pregnancy,
Right.
where your discomfort and everything sort of starts multiplying.
Mhm.
Even your clearance related concerns are more applicable in them, right?
Right.
So that's, and these are great topics.
So do you modify the prescription to increase the clearance?
Not, so early PED, you can increase your legitimate clearance to meet a KT/V, and what we do is liberalize it to, like, let's say 2.3 to 2.5, no data. Just randomly, we just increase STD KT/V to that level. We try and just monitor how long the patient it feels okay. Many a time when the person says, I want to become pregnant, they never become pregnant on HD or on PED. So none of them are sort of ready for a quote unquote, what is the rate? 28% fertility rate to go and switch the thing. So they all want to sort of see, if they do become pregnant, what do we need to do? And then once you do that, once they are pregnant, the early part, generally when the baby is really small, it usually turns out okay. And then somewhere along the line, they just are genuinely in discomfort, and you don't want to increase the valve volume or something. And that's when we sort of start making these changes.
So, in PD, so what Paola says that in HD, you try to do 36 hours a week. So is there any KD body goal that try to convert from like PD to?
So 2 data on the clearance side, I'm so sorry, I don't want to take over here. So 2 data on clearance side, I know she presented everything as a study, but most of them are retrospective data. And the actual origination of data is different. So the nocturnal group that we are sort of talking about, it started with Christian in Toronto. And so that group, that 48 hour per week, that Canadian data, is actually people who largely in the initial phase, somewhere between 95 to 2005, 2007 onward, they were already on nocturnal. So the first paper that came out was when I was there, and that's when they said, hey, and Christian, I remember him walking in saying that, hey, Michelle Adanovich is one of the PED expert, and say, what are you talking about? All my patients have reached, for example, full delivery, not full term delivery, but a live birth. So that was the early data which showed that liberalizing pregnancy outcome in people with liberalized or a lot of clearance has better outcome. Then came the next one where they did, after somewhere around 2000 something, where they switched their strategy and say, can I make people who are in center or on PD go on nocturnal? And that's where the second data comes from. For US, most of the time the problem is, you ask anybody to do 6 hours, 6 days a week, your dialysis units are going to freak out. So you have to sort of titrate that. The most I have seen happening is you can get daily shift, so 4 hours, 6 times a week. And so 24 hours is roughly what I have seen. They might give you an additional hour here and there, but most of the time, it's not, those are not very feasible target, so to speak.
And just to supplement that, it will be hard one, in addition to what you mentioned, is it's hard to have a concluding KTOR week or PD, right? Because most end up being switched to HD. So how do you assess what KTOR was good because you just switched them? So how do you assess the outcomes? So I guess his point is probably it's good clearance anyways, and you just intensify whatever you feel is good.
I would just not talk about KTOR on PD, even on HD, but at least not on PD.
Yeah.
So this 4 hours, 6 times a week, they have a good outcome.
So she showed, right? So I think a lot of US data, I don't know what's a good outcome here, but a lot of US data are maligned by the fact that the capitalistic nature of healthcare interacts with the medical aspect of it. And a lot of Canadian data is influenced by the fact that they conventionally do more home dialysis. So their younger population has generally even higher home dialysis. And so there is a selection bias that it is a more healthier population there. So there are a couple of things which are interacting here. Sorry.
Okay, so the prescription changes, right? So during the first trimester, they barely made any changes. You play it more by ear, but you can eventually, when they start to they're starting to grow and they're occupying more of that peritoneal space, you can start to decrease the total volume that they're going to have and just compensate by trying to increase more exchanges. There's not a lot of data, especially in like the first and second trimester. So that's when I was saying, right, you can keep essentially the same prescription and play it by ear. And receive renal outcome is associated with improved outcomes overall. So going on to delivery. In a lot of these patients, preterm delivery may be necessary, considered like as a necessary evil, especially in severe preeclampsia, to avoid fetal growth restriction or if there's like non-reassuring fetal testing. But most women that are on dialysis end up delivering at 37 just to avoid like further complications during that time while the baby is already ready, right? So they reported as this like benefit in allowing pregnancy to extend beyond those 37 weeks due to the increase or risk for the mother and for the perinatal risk is higher than the benefit. So we went through our 3 phases, right? The 3 things that you need to discuss with the patient and that you want to make sure to have their opinion on it and they are aware before deciding it. We talked to them about what we're going to do while they're pregnant, how we can adjust the dialysis, medications, and everything associated to that in our goals. And then what can be done around the pregnancy. So what am I going to tell her? So in a nutshell, and these are also some of like what I understood from reading everything for this presentation, I would tell them that women on dialysis are less fertile and overall less likely to become pregnant, but that there is evidence that with intensification of dialysis or transplant, we can help them and we can also help them improve fertility and have better outcomes of that pregnancy. Pregnancy while on dialysis will take up a lot of your time. If there's someone who is like the main breadwinner in the family and she is also like working and she doesn't have anyone else to help her out with kids or that she may already have, this is something that should be a factor. And I put this in because this is always what I worry about when I think about having kids. And I can even imagine someone who is on dialysis. You literally have to pause your life to be able to have a kid while on dialysis. And so this is something that should be a really important part of what we tell our patients so that they're able to make the correct arrangements and that so they make the correct decision also for them. So apart from the dialysis, all the testing, all the appointments, everything that you have to go through. And for the overall, due to the optimization of dialysis, more successful pregnancies are possible. But keeping in mind that the actual fertility right now is the main problem. So, that's it. Any questions?
Can I ask a question? The last slide.
Yeah.
So I wanted to ask you about fertility. So is there, and we talked about all the pregnancy outcome data with
Right.
intensification of dialysis.
Mhm.
Does it increase the chance of conception?
Yes,
Is there
increasing.
any
So
intent-
this is
would
the
you
way that
actively- Somebody mentioned I want to be pregnant. Would you intensify dialysis until they get pregnant? That's the question.
So what I read, and this is how I kind of interpret it from that study, and Dr. Shukla, you can correct me. But I understood from that study, from the patients who were on home hemodialysis, some of them were on regular dialysis before. And by moving them to home hemodialysis, even before intensifying, like to proportional to what you would do for a pregnant patient, if you consider like moving them to home hemodialysis, intensification of pregnancy, some of them became pregnant while in the home
Is there a control in
hemodialysis.
it? Like, how do you assess that you wouldn't want to be pregnant if you weren't on the home hemo? Like, there's,
What was the question?
like, there is no control in it, right? Like, control.
What isn't?
Like, theoretically, you can
Yeah.
make a study that people who desire to be pregnant, you can randomize them, standard of care is continue the same dialysis or intensify them and see how many 100 out of 100, how many end up becoming conception.
Right.
Like HCG positive or
Yeah.
something. That'd be good, but is that a thing?
No, that's not what
But that'd be
they
a
were.
question
They just
of a
like
patient, right?
extrapolated it because, oh, look, these patients that were already like on regular dialysis never got pregnant. We put them on home hemodialysis, they got pregnant. That's all that they were able to
That's
like tell us.
historical,
So that's
their own
like
history
where,
of
yeah.
control. It's not a bad question. I mean, patient will have that question, right? Like, should I
That's
use my dialysis if I can't get pregnant? Will
Yeah.
it help?
Right, yeah.
And again, in US, the only way you can do it is go to home hemodialysis.
Yeah.
You can't do
But
it.
PD, you can intensify, it's on the physician.
It's very difficult to intensify PD. Like, you know, you know this, but you know, the small solid clearance intensification of PD is
Sure.
only 168 hours.
Yeah.
So there is that limitation of small
Yeah.
solid clearance.
Yeah.
Chris Chen will tell you that he thinks that increasing this thing, I think it's a reasonable statement to make that greater clearance. I still have this wonderful figure from Matt Oliver from 2002 in Seminars in Nephrology, where he gave the proportional renal replacement that each renal replacement therapy provides. And it's like PD and in-center hemo provides somewhere between 10 to 15%. Short daily home hemo provides somewhere between 10 to 20 to 25%. And nocturnal, for example, provides around 40%, and transplant provides 50% replacement. So and that is what the general sort of dictum is, that yes, it might improve because it improves in transplant, post-transplant. But it's anyways.
So I have a couple of practical points. This was a great presentation. Number one is that aspirin is recommended for this. We don't know if
Yes,
you
of
mentioned
course.
it or not.
Yeah.
It is
I did not,
recommended
but
for
I should
these
have.
patients
Yeah.
that this is number one. Number two, that we have always read when we were in medical school and later that methyl-dopa is the preferred agent for treatment of this. Aldomet, the brand name, it doesn't exist anymore in US.
Okay.
It's only methyl-dopa and it is very almost non-existent. So you are left most of the time with nitrate. That's number two. Number three is that actually it is happening 6 hours a day, and it's not bad news for the unit. When you tell them that I am pregnant, it means that all of a sudden one patient becomes 4 patients. They do 6 hours every day.
Okay.
So they take 2 shifts every day all of a sudden. So it becomes a four, and also the last one is that for PD, I understand the ambition of Dr. Shukla, but at this level, it is more of a case report.
Yeah.
They can be done and all those, but wherever you go, it will tell you that the preferred method is dialysis. And the reason is that clearance of creatinine to begin with, it is half of dialysis. Then you want to add to it. It is very difficult, as you mentioned about the things. I do realize that, as Dr. Shukla says, it can be done, but it is really at the level of it can be done. Who does it would be a different story.
I mean, I think this is where we need to clarify this bit. So one is USRDS reports 9.3%. So this is a published data. It's out of here. So if we are counting this thing, 9.3% reported on PD. So it's no longer anecdotal. That's number one. But number two, I think what you are trying to make a point is and what I think everybody who manages dialysis patient on ESRD needs to understand is that we can't lump the entire thing together, month 1 and month 9. So I think what we should do is that, yes, PD is a very reasonable treatment while planning and in the early stages of pregnancy. But as you go along, you can't be dogmatic about whether the PD can sustain all the way to 9 months, because I think that's where the problem will happen. So I think maybe a reasonable position might be that if the patient wants to get pregnant, if you truly believe the data, go ahead and say that fertility is reduced in PD, which I don't think that there is a data on that. I think the thing is that one needs to know that somewhere along the line on PD, that you will reach a stage where you may not want to continue PD, and you should be ready for transitioning to
I
HB.
completely
In an-
agree.
in a-
I think
in-
that's actually what the idea is, that
Correct, correct,
you
correct.
can start, you can continue on PD, but at some point it is very likely that you want to. It is similar to calciphylaxis. You can't say that STS should be used, can be used in patients and while being on it, but how many people are really staying on it, and how many people are changing to hemodialysis while having calciphylaxis?
Yeah,
But
I
your
think
point is
I
that
probably would
they can.
universally change it. I think we should.
Yeah,
A common message is I probably would universally change somebody somewhere along 15-20 weeks when they are earlier if they want to, but if they do get pregnant and then there is an ongoing PD. So because I think right about there, a lot of things starts happening. And it just is genuinely discomforting for the patient.
that would be very reasonable approach. I think I agree with you on that actually. So actually, one thing also I have to tell you a personal experience about this is that how the maternal instinct is important. So I had a patient, 29 years old, who got pregnant. Right, so she had intermittent compliance, you can say. Tuesday, Thursday, Saturday she was, and Thursday, the majority of the time she was not showing. Right, she was just doing it twice a week. The minute she became pregnant, and she knew if she was pregnant, actually 5 months into pregnancy, she realized she was pregnant. So what happened is that she went to 6 hours a day, every day. She didn't miss even one session. She just went all the way 36 hours a week, all the way to the end of pregnancy. As a matter of fact, she had a twin, and she had her twin without any problem. So, and then after the delivery, she went back to the old habits. So that's for me, it's a lesson when we hear that some people that the maternal thing will
Yeah.
kick in. I saw it firsthand.
You're in my references, and I was asking around about the cases and things that I should include. I read your case for.
Yeah, it was so interesting because twin pregnancies, I think at least at the University of Florida, we haven't had it for the last 20 years, at least, if not more. So it's very rare. So it was very scary. And as Dr. Ikut mentioned, the rest of the things are pretty much like other pregnancies. But God bless when it comes to the weight. I had no clue what her weight was. And you have a twin and you don't know how much to add every week. Right, so it was really,
Yeah.
point of care ultrasound helped me quite a bit on this.
Oh,
And the OB was doing it, not me, OB was doing it every week,
to try to help you with like the size of
Yeah.
the baby.
to where to go, yeah.
Okay. Oh,
For the fluid.
awesome.
The oligohydramnios, polyhydramnios. Those
Oh,
evaluations.
nice.
And
Okay.
maternal fetal medicine is different.
I don't think about it.
Yeah.
Really.
Don't you normally also put your life on hold once you become pregnant and mother?
And after.
Like, don't you guys almost, so I think that's almost a universal suggestion. You're going to become a mother, put your life on hold for next 20 years.
Twins, and she's doing her.
Yeah,
Dialysis, she wouldn't be able.
She was 29, that was her 5th child.
yeah.
And I have to say, she just put everything on hold.
Yeah.
36 hours a week, you just think about it, it just blows your mind.
Dr. Shukla, may I have a comment about putting your life on hold? So some of us who have, been living in a professional environment for a long time, prior to starting a family and after,
You just have two lives.
It's not too exclusive, right? You just live your life and that's how you become more efficient.
I think you guys live
This is why.
300 and 36 hours in a week compared to us who live 168 hours a week.
Yeah, question.
Become more
Yes.
efficient, there's no other way, because.
What's your question?
I have a question. First of all, thank you very much for talking. My question is, after the delivery, the new mom are able to feeding their baby with breastfeeding or demand with the formula. Is there
So-
any study about that?
That, yes, there are. I didn't read too much on it. So I can look it up, the ones that I do have, and send you the data. But I know that that's an important part, especially when it comes to the medications that you're gonna be taking after and how the uremia affects it.
I have a clinical scenario. When I was a fellow, we had a patient,
Okay,
primary hyperaldosteronism, hypertensive, ESRD.
okay.
What would you do? Spironolactone, no spironolactone.
I mean, if we're able to control the blood pressure with any other way,
So he was on 4 pills.
oh no.
I'll tell you what we did.
Yeah.
In our fellows, we were discussing, we call OB, it's a male child or female child, fetus.
Okay.
We figured out it's a baby, girl baby. We're like, they're all so happy. Put on spironolactone.
Do you remember what it does to male fetus? I actually mentioned it in my lecture. It's lactone due to developing male fetus. Why do the big?
I just think you got to embryology and like extra.
Male fetus, yes, you can, ambiguous.
You can have like a bigger genitalia from it without like. the
My
dropping.
patient was on lisinopril for 5 months, the first 5 months
Yeah.
of pregnancy, no problem.
My patient was the same thing. She wouldn't know she's pregnant until like 3 or 4 months into it.
It's like 5 months into pregnancy, you realize you're pregnant?
And the baby turned out okay. Congratulations. This is a topic to pick up, yes.
Oh my God, yes. Thank you.
No, my next one.
And you.
And just